Hello, welcome to another session of Digital Slide Review and Sign Out. I'm Dr. Lewis Hassel in our program, part of the Digital Anatomic Pathology Academy, which DPA and Path Presenter have graciously allowed me to participate in. Our case today comes from the realm of orthopedic pathology. It's a 32-year-old woman. She's experienced a little bit of pain and loss of motion in her elbow. And so she comes for evaluation at the clinic and a plain x-ray is obtained. Now, as we look at these x-rays, we see that the striking abnormality here is actually the fact that there seems to be abnormalities in several of the bones. So looking here at her distal humerus, we see there's a degree of mottling in the marrow spaces, some variability in staining that appear within the medullary cavity that makes it look non-uniform. Then additionally, looking in the radius and the ulna, we see that there is a lytic lesion with some sclerosis, some lucency here, and again, this sort of nodularity and fashion of lucency affecting the marrow space within these bones. Moving on and taking a look at her MRI sequence, we can again see here on the fluid sequence that we have evidence of involvement in at least two bones here on this section with a high fluid content tissue. And on the fat sequence, again, we see multiple nodular areas here within the marrow involving several of the bones. This one, obviously, there's the humerus here and the radius and ulna here. So this raises a very interesting differential diagnosis in a young woman, relatively young, with multiple bones involved. So typically when we see multiple bones involved with lucent lesions, we think first of metastasis. This woman did have a family history of malignancy in multiple family members involving breast, colorectal, and other sites. So certainly she may be at risk for metastatic lesion. We'd also have to think about hematolymphoid lesions involving multiple lesions, multiple sites, but she's a little bit young for most of the adult type tumors. And a little bit old for most of the pediatric type tumors. We could also think about various syndromic type of lesions, Maffucci syndrome, various other possibilities, and potentially maybe we could consider vascular events leading to a shower of emboli or thromboses or something of that sort in this situation. Given the likelihood of one of these first two lesions, the next course after getting appropriate radiographic studies was to select a site for biopsy. And she actually had a small portion of tumor that extended towards the posterior joint space that might be accessible without transgressing the bone. And so a biopsy was obtained. This is a representative tissue section from that sample. As we see, it's very diffuse pattern, very bluish purple with mostly solid appearance and no real defining architecture other than a degree of vascularity associated with some hemorrhage. Going to higher magnification, we can see that these cells have slightly purpled cytoplasm, and honing in on the nuclei, we can see even at this magnification that they are really quite round, very rounded and uniform. And if we look very carefully, some of them where we can see details have the sort of slightly granular peripheral condensation of nuclear material that has been described variably as clock-faced or granular type nucleoplasm. Additionally, many of these cells have the nucleus sort of pushed off to the side. We can see that they sort of have this plasmacytoid appearance. And in a few of them, we can even see this perinuclear clearing, such as right there, which is characteristic of what's called the perinuclear Hoff. typically seen in plasmacytoid lesions. Here's another nice one right there. So as we look carefully, here was another binucleate cell. So this is looks pretty convincing for plasmacytic differentiation. And we would, of course, want to confirm that. Immunohistochemistry can be quite useful in confirming that, as well as to rule out possible mimics. The diagnosis of plasma cell myeloma is one of the considerations here, obviously. If it were a single bone, a single lesion involved, a soft tissue or bone, we might use the term plasma cell myeloma. But where multiple bones are involved, the more appropriate term is multiple myeloma. And this, of course, is also applied to situations where on random bone marrow biopsies you have evidence of clustered and nodular plasma cell aggregates. The morphology is very useful as we've delineated the nuclear features, the perinuclear halo or HUF, and then the immunohistochemistry with positive CD138 staining, light chain restriction of either kappa or lambda. And usually these neoplastic plasma cells are CD19 negative as opposed to more normal plasma cells, which would be positive. You want to exclude, plasmablastic lymphomas or lymphoplasmacytic lesions, but with a pure population and light chain restriction, you can make that data or make that diagnosis. Now, of course, it's very helpful to then synthesize the morphologic data, your bone marrow exam data, along with various clinical lab results to appropriately stage and provide prognostic information for the patient. So identifying a potential tumor marker in the blood using serum protein or urine protein electrophoresis, and then staging data with beta-2 microglobulin, albumin levels, LDH, and potentially cytogenetic study to evaluate for various translocations or chromosomal abnormalities which may adversely affect the prognosis. Interestingly, the IDH translocations are quite common in this disorder, usually restricted to one of several different oncogenes in the marrow. So our final diagnosis today, based on the morphology, is plasma cell myeloma with evidence of multi-bone involvement consistent with multiple myeloma, and by immunohistochemistry was kappa light chain restricted. And therefore, one might predict that the serum would also contain kappa light chains. Well, thank you so much for joining us for this brief review of the interface. This patient was somewhat young for plasma cell myeloma, but it's important to realize that the age range is not always found in older patients. So if you like that, please comment, share your thoughts. And of course, we'd appreciate it if you'd hit that subscribe button and share this with friends and colleagues who may be interested in that rad path correlation that we offer with this case. So until next time, thanks for joining us.